Today's class is on antiemetics and prokinetic drugs. Antiemetics means the drugs which are used in vomiting. Now, emesis means vomiting. Basically, emesis or vomiting occurs due to the stimulation of the vomiting center. Vomiting center is located in the medulla oblongata. Now, there are two important relay centers in the brain: chemoreceptor trigger zone, that is located in the area postrema, and nucleus tractus solitarius, where the afferents from the gastrointestinal tract, throat, labyrinth and other area, not labyrinth, gastrointestinal tract, throat and other viscera relay there in the chemoreceptor trigger zone and in the nucleus tractus solitarius. Now, from there the relay centers, they stimulate the vomiting center and the person vomit. Chemoreceptor trigger zone particularly, it has compromised blood-brain barrier. So, it is also accessible to the blood-borne drugs, mediators, hormones, toxins and others. Now, this is the vomiting center, is a nucleus tractus solitarius and the chemoreceptor trigger zone. Now, what happens on gastrointestinal irritation caused by chemotherapy, radiation, any infection, or it can be drug-induced event, there is release of serotonin from the enterochromaffin cells of the gastrointestinal tract. Now, this serotonin in turn they stimulate the visceral or the vagal afferent nerves that carry the impulses to the chemoreceptor trigger zone or the nucleus tractus solitarius, and thus is responsible for vomiting. Again, when serotonin is released in the excessive quantity, some of them even spill over in the blood and they can stimulate the chemoreceptor trigger zone directly, blood-borne induced, causing vomiting. Again, coming to the labyrinth. Now, this labyrinth basically there is a neural pathway from the labyrinth to the cerebellum. Here cerebellum is the relay center. From the cerebellum, it directly stimulates the vomiting center. Now, there is a cholinergic link, muscarinic receptor in this pathway. Emesis occurs in the emetic response. The fundus and the body of the stomach, the esophageal sphincter and the esophagus, it relaxes, and the pylorus of the stomach and the lower part of the duodenum, it contracts, leading to the vomiting. Now, what are emetics? Emetics are the drugs which basically causes vomiting. Now, there are two drugs that can cause vomiting. These are apomorphine and ipecacuanha. Now, they are used only when a poison is ingested, unfavorable substance is ingested, and it has to be removed out. So, the drugs are apomorphine that act directly on the chemoreceptor trigger zone, and ipecacuanha, it acts reflexly by irritating the gastric mucosa, leading to vomiting, or they also act directly on the chemoreceptor trigger zone. Now, coming to the apomorphine, apomorphine is a dopaminergic agonist that act on the chemoreceptor trigger zone. Now, chemoreceptor trigger zone has got many receptors there. You see, serotonin 5-HT3 receptors, dopaminergic D2 receptor, muscarinic, histaminic H1 receptor, neurokinin 1 receptors, serotonin 5-HT3 receptor is there, opioid new receptor and cannabinoid 1 receptors. Many receptors are there. So, apomorphine, it acts as a dopaminergic agonist acting on the D2 receptor in the chemoreceptor trigger zone. Now, it is given parenterally, either intramuscularly or subcutaneously. Action is prompt, vomiting is induced within 5 minutes generally. Now, problem is that it has got some inherent central nervous system and respiratory depression property. So, the person having respiratory depression should not be given the drug. Apomorphine also has a therapeutic effect in Parkinsonism because it blocks the dopamine D2 receptors. Because it's a dopaminergic agonist. So, it has a therapeutic effect in Parkinsonism, but is not used because of its side effect. Now, coming to the another drug, Ipecacuanha, it is derived from the dried roots of Cephalis ipecacuanha containing emetin. It is available in the market as syrup Ipecac for inducing vomiting. It is lesser efficacious than apomorphine. Slower acting, induces vomiting in 15 minutes or more, but it is safer and a good household remedy. But it acts reflexively by irritating the gastric mucosa, as well as it acts directly on the chemoreceptor trigger zone. Now, where the emetics should not be given, contraindications of emetics. Number one, in case of corrosive acid or alkali poisoning, there is a risk of perforation of the gastrointestinal tract. So, there is a risk of esophageal rupture and damage to the esophageal mucosa. Number two, in case of CNS stimulant drug poisoning, convulsion may occur. In case of kerosene poisoning, there is a risk of aspiration pneumonia. In unconscious patient, as the laryngeal reflex will be absent, there is a risk of aspiration pneumonia in unconscious patient. Morphine or phenothiazine poisoning, the drug may not act. Now, what are the antiemetic drugs? Antiemetic drugs are the drugs that are used to prevent or treat vomiting. Now, the drugs are anticholinergics that include hyoscine dicyclomine, H1 antihistaminics that include promethazine, diphenhydramine, dimenhydrinate, doxylamine, meclizine, all first generation antihistaminics. Neuroleptics, that is D2 blockers, chlorpromazine, triflupromazine, prochlorperazine. Prokinetic drugs, metoclopramide, domperidone, cisapride, mosapride, etopride, levosulpiride, cinetapride. 5-HT3 antagonist, ondansetron, granisetron, palonosetron, ramosetron. NK1 receptor antagonist, aprepitant, phosphaprepitant, adjuvant antiemetics that include dexamethasone and then benzodiazepines and dronabinol. Now, among them, the very important topics for your MBBS are metoclopramide, ondansetron and domperidone. Okay. Now, coming to anticholinergics. Anticholinergics, the drugs which are used are hyoscine and dicyclomine. Hyoscine is a drug of choice in motion sickness syndrome. What do we mean by motion sickness? Anyone? Is the vomiting or nausea or vomiting caused during motion, like in train journey or in the bus journey and the car journey. So, it is the most effective drug for motion sickness. Action is brief, so it is used only in case of brief journeys. And basically the problem is anticholinergic side effects like drying of mouth, sedation. A transdermal patch of hyoscine is also available containing 1.5 milligram of hyoscine that is delivered over 3 days. It is applied behind the pinna and basically it suppresses the motion sickness while producing minimal side effects. Now, coming to dicyclomine, it is used for the prophylaxis of motion sickness and can also be used for morning sickness. Morning sickness means is basically the vomiting tendency in the pregnant mother, particularly seen in the first trimester. Now, it has been articulated. Now, coming to the second group of drug, H1 antihistaminics. Now, H1 antihistaminics, some of them they are used as antiemetics. They are useful in the motion sickness syndrome and to a lesser extent in morning sickness, in post-operative vomiting and other forms of vomiting. Their antiemetic effect is seen due to anticholinergic property, antihistaminic property because of their sedative property and antidopaminergic property. Now, Among them the drugs promethazine, diphenhydramine and dimenhydrinate. These are drugs, these are drugs that afford protection for morning sickness for about 4 to 6 hours. Problem again, anticholinergic side effects, dryness of mouth, sedation, and the patient during its action should be advised to avoid driving. Now, it's basically, as it has got central anti-dopamine, anticholinergic action, they block the extrapyramidal side effects of metoclopramide and supplementing its antiemetic action. Now, metoclopramide is a commonly used antiemetic drug. It acts primarily by D2 blocking action and also has got action on the 5-HT receptors. Now, because of blocking D2 receptor, metoclopramide, it may cause extrapyramidal side effects. Now, these extrapyramidal side effects are antagonized by the anticholinergics. So, they are antagonizing the extrapyramidal side effects of metoclopramide and again supplementing its antiemetic action. Combination of these antihistaminics with other antiemetics has also been used in chemotherapy-induced nausea and vomiting. Now, chemotherapy drugs or radiation therapy, they are used in cancer patients. Now, these drugs, some of these drugs have got high emetogenic potential. Now, promethazine thiacholate is another salt of promethazine hydrochloride they are promoted especially for antiemetic action, but it is similar to that of promethazine hydrochloride. Doxylamine. Doxylamine is again a H1 antihistaminic. It has got sedative H1 antihistaminic action with prominent anticholinergic activity. Now, this drug doxylamine in combination with pyridoxine, it has been approved by American College of Obstetricians and Gynecologists as the first line drug for the morning sickness. It is also used in India, but it is not used for this purpose in UK and many other countries. Meclizine is again an H1 antihistaminic, less sedative, less anticholinergic and longer acting. It is used in case of seasickness syndrome and acts for about 24 hours. Cinnarizine. Cinnarizine is again an H1 antihistaminic. It is an anti-vertigo drug used in vertigo, and again it has got anti-motion sickness property. It basically inhibits the influx of calcium from the endolymph into the vestibular sensory cells and thus possibly responsible for its anti-vertigo and anti-motion sickness action. Now, coming to motion sickness is a common syndrome that occurs due to any type of movement. The hallmarks are nausea and vomiting. Here, antiemetics having antihistaminic and anticholinergic properties are effective. Antidopaminergic and anti-serotonin drugs are less effective here. Now, generally, the drugs are preferred as prophylaxis of motion sickness. When the vomiting starts, most of the drugs are ineffective and has to be given in higher dose or parenteral route. Now, coming to the morning sickness, the antihistaminics can be used in case of morning sickness, but better to be avoided. The drugs that are used are doxylamine with pyridoxine combination, dicyclomine, promethazine, prochlorperazine, metoclopramide may be prescribed in low doses if needed. Coming to neuroleptics, neuroleptics basically they are dopamine D2 receptor blocking drugs. The older neuroleptics, phenothiazines, haloperidol, they are potent antiemetics and sedative. Now, they block D2 receptor in the chemoreceptor trigger zone and antagonize apomorphine induced vomiting. Now, they are less effective in the motion sickness. Now, a spectrum of antiemetic action of neuroleptics, they can be used in drug induced or disease-induced vomiting, in case of post-operative nausea vomiting, malignancy-associated vomiting, chemotherapy-induced vomiting, radiation sickness vomiting, though less effective, morning sickness can be used, better avoided uh, until unless the need is there. Most of the drugs, they produce sedation, hypotension may occur, acute muscle dystonia is a great limitation of drug, especially in the children and girls. Now these agents should not be administered until the cause of vomiting has not been diagnosed. Otherwise, the symptom of the disease will be obscured. Now chlorpromazine, prochlorpromazine, basically these are labyrinthine suppressant. Now it is highly effective when given in injection form in the vertigo associated with vomiting, and to some extent in case of chemotherapy induced vomiting. It is used as antiemetic, not as antipsychotic. Muscle dystonia and other extrapyramidal side effects are the most important limitations. Dystonic reactions are common in children. Now coming to the prokinetic drugs. What do we mean by prokinetic drugs? So basically the drugs which increase the gastric motility are called prokinetic drugs, and the important thing is that they enhance gastric emptying by coordinated muscle contractions. Now anticholinergics or the traditional cholinomimetics, they also contract the intestinal muscles, but the contractions are not coordinated. Now coming to the metoclopramide. Metoclopramide, basically it is used as a gastric hurrying agent. It basically decreases the gastric emptying time or makes the gastric emptying faster. Now its action is most prominent on the upper gastrointestinal tract. It has got no action on the colonic motility. It speeds up gastric emptying by relaxing the pylorus and the first part of the duodenum, and increases the tone of the lower esophageal sphincter. Now action on the central nervous system. It acts on the chemoreceptor trigger zone, acting on the D2 receptor. It blocks the D2 receptor and thus blocks apomorphine induced vomiting. As it antagonizes D2 receptor in the brain, the problem is the drug may show extrapyramidal side effects and increases the prolactin release. Now mechanism of action. Number one, it antagonizes D2 receptors both centrally and peripherally. Thus, it decreases the gastric emptying time, hastens the gastric emptying and enhances the Elias tone. The central anti-dopaminergic action on the chemoreceptor trigger zone is also responsible for antiemetic property, and because of the D2 blocking action, it causes extrapyramidal side effects and hyperprolactinemia. Again, the other mechanism of actions are number one, 5-HT4 receptor agonism. Now these 5-HT4 receptors, they are present in the primary afferent neurons of the enteric nervous system, and when they agonize these receptors, the serotonin is released in the greater quantity, more serotonin is released, and that is responsible for the decreased gastric emptying time. Again, it has got some weak 5-HT3, it should be 5-HT3, and they have got weak 5-HT3 antagonistic property, and because of this also these 5-HT3 receptors are present in the inhibitory interneuron of the enteric nervous system, and thus they basically, by blocking 5-HT3 receptors, they again are hazarding gastric emptying. Now interaction, as they are decreasing the gastric emptying time, some of the drug absorption may be decreased, like aspirin, diazepam, digoxin. Now secondly, as they are blocking central dopaminergic receptors, the efficacy of levodopa is abolished. Now adverse effects, Generally well tolerated, sedation, dizziness, loose stools may be seen. The important side effects are extrapyramidal side effects, muscle dystonias, and long-term use can cause Parkinsonism, galactoria, gynecomastia. Now, uses, it is used in as a number one antiemetic drug, effective and popular drugs for many types of vomiting like post-operative drug-induced disease-associated radiation sickness. They are less effective in morning sickness, motion sickness. Why? Because in the vestibular pathway there is no dopaminergic link. Now, they are used as gastrokinetic to accelerate gastric emptying. Now, কোথায় gastric emptying hasn't কমানো gastric emptying time কমানো দরকার আছে? In case of emergency operations, where emergency general anesthesia has to be given and the person has taken the meal within 4 hours, then there is a afraid of aspiration pneumonia. To prevent this drug can be used to decrease the gastric emptying time. Number 2, it can also be used in diabetic gastroparesis and in case of post-vagotomy patient. In dyspepsia and other functional GI disorders, symptomatic relief is obtained. GRD in milder cases, PPI are the drug of choice, H2 blockers can be used. Now, coming to the second drug, metoclopramide mechanism of action ki ache? Mechanism of action of metoclopramide? D2? Sorry? Blocking action, number 1. Number 2? 5-HT3? Huh? The important is 5-HT4 agonism, and there is also a weak 5-HT3 antagonistic property. Huh? No, anticholinergics. Next রয়েছে, what the important side effect of metoclopramide? এখান দিয়ে important side effect of metoclopramide, muscle dystonia because of D2 blocking action. আর কি আছে? prolactin release টা বাড়াবে, hyperprolactinemia, gynecomastia. These are the important side effects. Now, coming to the next drug, domperidone. metoclopramide কিন্তু খুব important topic রয়েছে MBBS এ পরীক্ষাতে. Now, coming to the domperidone, unlike metoclopramide, it has got no action on the 5-HT receptors. It has got significant D2 receptor antagonistic property. Number 1. Number 2, it is lesser efficacious than metoclopramide. Number 3, it does not cross the blood-brain barrier. As it does not cross the blood-brain barrier, it has got no extrapyramidal side effects, although it is blocking D2 receptor. But as chemoreceptor trigger zone has got deficient blood-brain barrier, so it can act directly on the chemoreceptor trigger zone and thus have central antiemetic action too. Now, as it does not cross blood-brain barrier, it does not antagonize the effect of levodopa. And again, although it does not show extrapyramidal side effects, rare, but it can cause increase in prolactin level, domperidone. Side effects are few: dry mouth, loose stools, headache, rashes, galactoria may be seen, but is mild. On rapid IV injection, cardiac arrhythmia may occur. Now, it is an antiemetic drug that is used for mild to moderate cases in post-operative drug and disease induced, but is not effective in severe cases. Now, it is also not useful in motion sickness because it has got no anticholinergic or antihistaminic action. So, it is not useful in motion sickness and is not advised in morning sickness. Now, coming to the next drug, cisapride. Cisapride is another basically prokinetic drug. Now, its prominent basically is a bench amide derivative. It lacks D2 receptor antagonism. It's prokinetic with little antiemetic property. Effects of cisapride on gastric motility resemble metoclopramide. That means it contracts the basically it relaxes the pylorus of the stomach, relaxes the duodenum, and basically cause increased LES tone, lower esophageal sphincter. Now action is exerted through 5-HT4 agonism. It should be 5-HT4. Action is exerted through 5-HT4 agonism and weak 5-HT3 antagonism. Now again, because of the action of the 5-HT4 receptors on the colonic mucosa, there is increased chloride secretion that increases the water contained in the stool, and thus loose stool may occur. Now this drug cisapride has got action on the colon also. Now it is devoid of action on the chemoreceptor trigger zone. It does not cause extrapyramidal side effects. It does not increase prolactin. One important question in the MBBS: why cisapride has been banned in India and other countries? Now cisapride, কেন করছে? How? কিভাবে করছে? In the cardiac action potential, in the phase 3, basically there is a plateau phase that is caused by delayed rectifier potassium channels. Now what happens? Cisapride in higher doses, it blocks these delayed rectifier potassium channels and thus causes QT prolongation. Now problem is that cisapride is metabolized by CYP3A4 isoenzymes. Now when we use the drug, we co-administer the drugs with CYP3A4 inhibitors like erythromycin, ketoconazole. Now when cisapride is co-administered with CYP3A4 inhibitors, then the level of the cisapride is increased in the blood, and hence QT prolongation occurs, and there is a risk of torsades de pointes, which is a life-threatening condition. So due to the several reports of torsades de pointes being reported, cisapride has been banned in India and other countries. Now coming to the mosapride, is again a congener of cisapride with similar gastrokinetic action due to 5-HT4 agonism measure and weak 5-HT3 antagonistic action. No clinically useful antiemetic action and does not produce extrapyramidal side effects or hyperprolactinemia. Now some reports of QT prolongation has been obtained with mosapride use also, but this drug still is not banned in India, but may not be safe although. So it should be cautiously used if needed. The efficacy is not impressive. Etopride. Now etopride is again a prokinetic drug which basically developed in the Japan. Now it has got D2 anti-dopaminergic action. Number one, it's different from cisapride and the mosapride. It has got D2 anti-dopaminergic action and anticholinergic activity. They have got lower affinity to the 5-HT4 receptors. Now for this, they are unlikely to cause cardiac arrhythmias. Number one. Number two, these drugs, etopride, is not metabolized by CYP3A4. It is metabolized by flavin monooxygenase, and as a result, is devoid of drug interaction with CYP3A4 inhibitors. Side effects are diarrhea, abdominal pain, headache, galactorrhea and gynecomastia occur infrequently. No extrapyramidal side effect. Now coming to the levosulpiride. Levosulpiride again has got peripheral D2 receptor blocking activity as well as central D2 receptor blocking activity. Although D2 blocking activity, it is not used, it has got a typical antipsychotic, but it is not used as antipsychotic. It has prokinetic action and antiemetic property. Coming to cisapride. Cisapride is a benzamide derivative gastrokinetic drug developed and marketed in Spain India and other countries. Now, it acts by 5-HT2 receptor antagonism and dopamine D2 receptor antagonism. It also stimulates 5-HT4 receptors. It is indicated in functional gastrointestinal disorders. Now, comparative value with other prokinetics has not been adequately evaluated. Driving is not advised, no QT prolongation or arrhythmia is seen. Now, coming to ondansetron is again a very important topic for the MBBS. Now, it's very different from the prokinetic drugs. It is used as an antiemetic drug. It was particularly developed to control the cancer chemotherapy induced nausea and vomiting and the radiation therapy induced nausea and vomiting. Now, what does it cause? It preferentially block the 5-HT3 receptors. Now, these 5-HT3 receptors are present on the vagal afferents in the gastrointestinal tract, and they are also present in the centrally in the chemoreceptor trigger zone and in the nucleus of tractus solitarius. Cytotoxic drugs, radiation produce nausea and vomiting by causing cellular damage. Already বলেছিলাম প্রথমেই, which release serotonin from the enterochromaffin cells and that acts on the vagal afferents in the gut, resulting in transmission of emetogenic impulses. Now, ondansetron blocks emetogenic impulses mainly at the peripheral origin in the gastrointestinal tract and in the central relay, that is chemoreceptor trigger zone and in the nucleus of tractus solitarius. Now, it has got no action on the dopamine receptors. It has got no anticholinergic property. It has got no antihistaminic property. A minor 5-HT4 antagonistic action has also been shown, but no clinical relevance. It has got no clinically significant drug interactions. Now, in patients of vomiting not responsive to ondansetron, we can combine the drug with dexamethasone, or we can combine the drug with first generation antihistaminic promethazine or a benzodiazepine diazepam. We can also combine the drug with NK1 receptor antagonist, that is aprepitant, to enhance the antiemetic activity. Now, particularly cisplatin induced vomiting, we see two types of vomiting. One is acute phase seen on the first day of the therapy and the delayed phase seen from 2nd to 5th day. Now, ondansetron is very much effective in the acute phase of vomiting. In the delayed phase, generally other adjuvant drugs has to be added to control the vomiting. Now, they are also effective in prevention and treatment of post-operative nausea vomiting. Ondansetron is very much superior to control vomiting. It's very much efficacious and safer than other drugs, including metoclopramide and phenothiazines. It is not effective in anti-motion sickness. Vomiting occurring as a side effect of drugs or due to drug overdose, gastrointestinal disorders like gastroenteritis, uremia, neurological disorders are also suppressed. Efficacy in motion sickness is poor. Could be used in pregnancy only when unavoidable, like in case of hyperemesis gravidarum. Hyperemesis gravidarum ki ache? During pregnancy, when there is excessive vomiting, that basically disturbs the day-to-day life activities. That is called hyperemesis gravidarum. It is well tolerated drugs. Side effects are mild headache, dizziness, mild constipation and abdominal discomfort may occur. Hypotension, bradycardia, chest pain, allergic reactions have been reported on intravenous injection. Now, coming to granisetron, 10 times more potent, more effective in repeated cycles of chemotherapy. When the chemotherapy has to be given for repeated cycles, then ondansetron may not be that effective, where granisetron can be preferred. It has got weak 5-HT4 blocking action is not seen with this drug. Plasma half-life is longer. It is used in twice daily dosing. Coming to palonosetron is again longer acting drug. Now, it is used particularly in case of delayed phase of chemotherapy-induced nausea vomiting. Palonosetron, basically it has got additive QT prolongation may occur, rapid IV injection can cause blurring of vision. Ramosetron developed in Japan possibly. It's a potent 5-HT3 antagonist. Now this drug is particularly used for diarrhea associated irritable bowel syndrome. It has got action on the whole of the gastrointestinal tract. NK1 receptor antagonist, basically it antagonizes the NK1 receptors present on the relay centers which are activated by substance P. Aprepitant is a recently introduced selective high affinity NK1 receptor antagonist. Now it enhances the antiemetic efficacy of the ondansetron to protect up to 90% of patients against high emetogenic cisplatin based chemotherapy. It is also effective in delayed phase of vomiting. Now it can also be used in multiple cycles of chemotherapy. It is equally effective in the post-operative nausea vomiting and good tolerability. Coming to the adjuvant antiemetics, corticosteroids, particularly dexamethasone. Now, it augments the efficacy of other primary antiemetic drugs, possibly because of anti-inflammatory action in the delayed phase of cisplatin-based chemotherapy-induced vomiting. This drug can be combined with ondansetron. Now, benzodiazepines. Benzodiazepine shows antiemetic action possibly because of its sedative property. Now, they also suppress the dystonic side effects of metoclopramide. Cannabinoids, tetrahydrocannabinol, they possess antiemetic activity against moderately emetogenic chemotherapy. They act on the CB1 receptor. Dronabinol is a pure tetrahydrocannabinol. It has got hallucinogenic potential. This causes disorientation and other central sympathomimetic effect is there. It can cause addiction. Abuse liability is high. Digestants. Now, after prokinetic drugs, digestants basically are used to, they are claimed to promote digestion of the food. Now, here proteolytic, amylolytic and the lipolytic enzymes are mixed in a solution. So, a number of proteolytic, amylolytic, lipolytic enzymes are marketed in combination formulations. They can be helpful if the digestive enzyme secretion in the body is decreased. But in most of the cases, their use are irrational. They include pepsin, papain, pancreatin, diastase, tacadiastase. Now coming to methyl polysilaxone, it is also known as simethicone or dimethicone and others. It is an anti-foaming agent, pharmacologically inert. It is not absorbed from the GIT. It is promoted as a remedy for hyperacidity. Now it is claimed to coat and protect ulcer surface, aid dispersion of antacid in the gastric content and to prevent reflux. Gallstone dissolving drugs. Gallstone dissolving drugs, as the name suggests, these drugs are used to dissolve the gallstones. The primary therapy of gallstones are, the definitive therapy for the gallstone is surgery, cholecystectomy. Now, where the surgery is not indicated, cannot be done, there these drugs can be a choice. Now, why the gallstone formation occurs? Because of the high cholesterol is to bile salt ratio. Now, chenodeoxycholic acid and ursodeoxycholic acid, they decreases the cholesterol content in the bile and thus they solubilizes the cholesterol crystals and thus help in gallbladder stone dissolution. The problem with chenodiol is that it is less effective than ursodiol. Number one, it frequently causes diarrhea, increases the LDL cholesterol level and carries risk of liver damage. So, cyanodeoxycholic acid not used for gallstone dissolving action, but we would use ursodeoxycholic acid for that. Ursodiol or ursodeoxycholic acid is more effective, needs to be given at lower doses. It has to be given for prolonged periods, for 6 to 24 months, but recurrence is high. It promptly reduces cholesterol secretion into bile, promotes solubilization of biliary cholesterol by liquid crystal formation. It also inhibits cholesterol absorption. It does not increase the LDL level, unlike cyanodeoxycholic acid. It is more likely to succeed in patients who have a functioning gallbladder with small floating gallstones. It can breach the gastric mucosa, predisposing to ulceration. Patient compliance is very poor and recurrence is common. Thanks.